Hi, this is Dr. Donald Pelto. I want to go over this little recording of a lecture that I'll be giving soon to the University of Massachusetts Emergency Room Medicine. And this is going to be a lecture of common foot injuries that you can see in the foot in the emergency room and how to treat them. And I'm going to go over it with some special details of how to actually do cortisone injections and things like that, and anesthetic injections for the toe. Okay, I'd like to start out here and talk a little bit about ingrown toenails. You see the different types of ingrown toenails that there are. Some are just on the side, some are curved in, and some are actually very, very large. The main thing I want you to realize is that when you do this, you need to remove a portion of the toenail to make it feel better for these patients. And you have to inject the toe. Now, I don't recommend injecting at the end, as I show here in the picture. Don't inject it right in the end. You want to inject it back here. Don't use a little piece of wood right here, and don't use this toenail remover. This can cause a lot of danger in doing these types of procedures. Here you can see some interesting pictures here showing this is after a matrixectomy procedure that we do in the office, and there are some videos online that you can watch on how to do this. Okay, here's an article. Should you desire to learn more, you can certainly look at that article. Hope that helps you understand this a little bit more. Okay, next I want to go on to heel pain. Heel pain is something else that's seen a lot of times in the emergency room, and it can be a little confusing. As you can see, there's some journal articles here for anyone that wants to look up and get more information on this. But the big dilemma is really diagnosing the difference between plantar fasciitis, or heel pain, which is right here where the plantar fascia inserts into the heel, Achilles tendonitis, which tends to be on the back of the heel, right around here on this tendinous area, and then where it inserts into the heel bone, that's where you get the Haglund's deformity, right here. That's where that bump is on the back. And you really have to distinguish between the three of them. Usually I get an x-ray to see if there's not any injury or a stress fracture to the back of the heel. But then the treatment is for the most part stretching to this area. By stretching out the Achilles tendon, you're going to help reduce some of the pressure on the plantar fascia. You can also try an over-the-counter insert. But really the mainstay is a cortisone injection. So I brought one of those actually to show you as well. The way a cortisone works is you want to inject it, I'll show you, from the side of the foot right in this area. Right here, you just kind of go down and you hit down to the bone and you pull off a little bit, and that's going to drop the mixture, the cocktail that I use. I use 1% lidocaine, 0.5% marcaine, and then dexamethasone and methylprednisone. So I use 3, a short and a long-acting steroid and a short and a long-acting Novocaine. For Achilles tendonitis, I don't usually do an injection. I usually recommend physical therapy. And then for this Haglund's deformity, you'll see a big bump back here. And sometimes you can do a little bit of an injection of a cortisone away from the Achilles tendon if there's a bursa in there. But for the most part, we don't like to do that, just icing the area. All these are good for treating it with icing, stretching, and then you may even want to put them into a walking boot. People can really come in with a lot of pain from plantar fasciitis. The typical signs that they feel is when they get up in the morning, they have really bad pain. It's because everything as they sleep gets tight, and then when they wake up, they pull, and that injures that area. As they start walking, everything loosens up, and then as they sit down again at work or in the car, and then they get up again and it hurts. That's typical what they see. The next one I see a lot from the emergency room that's even hard for us in the office is distinguishing between a stress fracture, metatarsalgia, capsulitis, or neuroma. Those are all kind of big terms. Stress fracture is easy enough. Here's an example of a stress fracture, and you can see actually this halo around it. That's the callus formation that's developing. So typically what you do is you take a tuning fork and put it on that area, and if it vibrates and is painful, it's most likely a stress fracture, even if it doesn't show up on an x-ray. Because a lot of times the stress fracture doesn't show up right away on the x-ray, and I treat them by immobilizing them in either a walking boot or a walking shoe. The next would be metatarsalgia. The metatarsal is this bone right here. So algia means pain, metatarsal, so a painful metatarsal. It can be painful anywhere, but if it's painful right around here, it may be the bone that's injured. There could be the beginnings of a stress fracture, or what we call bone marrow edema, or swelling inside of the bone. There also could be bursitis or capsulitis, and that's why I kind of have this little image right here. So bursitis tends to be around this blue area. Can be a painful bursa underneath the bone. There can also be capsulitis. Capsulitis is a little bit further forward, and this may be from one of the toes, as we see it kind of dislocate. So you can do a Lockman procedure where you kind of lift it up and try to dislocate it. If it's able to dislocate, you may have either a capsulitis or even a tear of something called a plantar plate, and that's that little device that holds down the area right here. So those are kind of some differentials. And one thing I put a kind of a picture up here that you always want to check out as well is if there is a Freiberg's infarction. This is just an avascular necrosis or a lack of blood supply to the second metatarsal head, and it actually flattens out, and it usually has a bump on the top and the bottom a little bit, and that's quite painful for people as well. Okay, the next one I want to go over is the difference between a wart and a corn. These are or a callus. These are very tricky. The main difference I want to show you, if you look very closely at this, see how there's skin lines right here? And here there's an interruption of skin lines because it interrupts it. This is a wart. This is a mosaic wart because there's hundreds of warts in here, but it interrupts the skin lines. That's the main thing I want you to see. And here's a callus down here, and you see the callus, the skin lines go into the callus. So that's the main way you can tell the difference between a callus and a wart. The only tricky one sometimes is this thing. This is called a porokeratoma, where it's actually a clogged callus inside of it, and you can kind of dig that out. But how do you treat these? Usually start them on some topical acid, but don't put it on too much because it can make it really white around the edge. Okay, for the wart. In our office, we tend to use laser therapy, but if it's on a bony prominence, it can be quite painful for someone. So you may even need to put them into a special surgical shoe or a boot, or even take some felt or a pad and offload that area. Here's an example of the heel. You tend to debride it down, starting with a razor blade. I don't recommend people do that at home. Have a professional do it, and then afterwards there's some products I use called Sleep and Heal or some calcilyc cream to kind of calm down the callus. Here's a couple of other ones. These are over bony prominences for the most part, and so a way of treating this would be to do a hammer toe surgery or something like that. Okay, so let's go back here. So the next one is a differentiating between an ulcer and a callus. The way I always explain it, and this is a really good article by Dr. Armstrong and et al. Here, preventing foot ulcers in patients with diabetes. An ulcer is different than a callus. For the most part, I had a patient the other day. He had a callus for a long time. I wasn't trimming it down, didn't want it trimmed down, and eventually it turned into an ulcer. If a callus gets big enough, what happens is you trim down that callus, and underneath it actually changes the skin, because the focus of the pressure is kind of like a magnifying glass. The more callus you have, the more that that area just kind of funnels down and focuses on the central area. So you have the big callus up top, and then it focuses down to a peak pressure underneath it. So there's a little bit of an ulcer. Here's an ulcer on the bottom. It looks like it's the beginning of an ulcer down there. And here are two ulcers. Now, these are mostly caused by biomechanics, by the way that someone walks, by having either a tight heel cord to put more pressure under the front of the foot, or by having mechanics so that this joint doesn't move, so it's getting all the movement out of this joint. This one just plain has an infection. You can see the redness. They need to be on antibiotics. You need to just wait for this skin to turn to be normal if they have good blood flow. But you can see that all this yellowish stuff is fibrotic tissue, and that needs to be changed into this beefy red tissue. That's what you want to see, beefy red tissue. Now, about the emergency room residents, the reason I bring this up is patients may come in saying they need pain medicine for this. For the most part, these aren't painful, so you shouldn't be giving them pain medicine because occasionally people can have painful ulcers, but for the most part, they don't hurt because they have neuropathy. So just something to kind of keep in mind. Treatment, the mainstay is to make sure they have good blood supply. Maybe you need a vascular or a consult to make sure that there's no bone infection with an x-ray, and then offload the area and clear up the infection with any antibiotics. So you may need an infectious disease consult as well, or a podiatry consult. So that's kind of how you treat the difference between ulcers and calluses. And the last thing I want to end with is just something that happens in about 1% of all diabetics. It's called Charcot foot. I just like to address it because many times patients are seen in the emergency room for a foot that's red hot and swollen with no opening in the skin. The telltale sign is that there's no opening. If there's no opening in the skin, no ulcer, you're not thinking infection, you're not thinking osteomyelitis. The first thing I'd like you to think of is Charcot foot. So you see this red hot swollen foot, no opening in the skin anywhere. You're looking at a stage 0 Charcot. It's where it's a hot foot, normal x-rays, the MRI, the MRI shows bone swelling and fractures in there. And what happens with this is the way, there's a couple of theories behind it. One, there's a lot of blood flow going to the area and everything kind of breaks down. The other one is a little bit of trauma and they injure it. They step off the curb, they do something, but most people don't recognize they do anything. The most common area for Charcot is right here in the middle of the foot. It also can be in the ankle or in the back of the foot or even in the front of the foot. What happens basically is someone doesn't have feeling in their foot because they have neuropathy. Most of the time they have diabetes. This can also be seen with syphilis and some other diseases. But they do something, step off the curb, walk, hit their foot on something, they might not even know it, or even just walk a little bit too much, and it causes a break in the foot. But they don't know it, and so it gets red, it gets swollen, it gets hot. They think it's infected because they keep walking on it, but usually by keeping these people in bed off their foot, the redness comes down. Even though they're on antibiotics, someone thinks, well, it's the antibiotics that are working. Well, usually it's not. Usually it's just keeping them up and off their foot. So the standard of care when someone has something like this is get them on crutches or a wheelchair. Don't put any pressure on the foot until it's determined otherwise. Otherwise, it's going to continue to break down and kind of dislocate in that area. And there's the phases. So you have the stage 1, fragmentation, and bone resorption, dislocation, and fracture. That's where everything just kind of fractures. If you're walking in this stage or this stage, everything's going to kind of break down. Afterwards, everything kind of coalesces, everything heals. This can take a long time, and then the remodeling as it starts to heal in there. That can take up to 6 months. So when someone comes in with something like this, you have to rule out the infection, certainly, but for the most part, it's Charcot. Once again, it only happens maybe in 1% of the diabetics, but you're probably seeing it, and maybe even having them leave walking. So the key is to give them crutches or a wheelchair, so that have them not walk on it till it's proven otherwise. And it may take about 6 months for them to not put pressure on the foot to get this to heal. So I hope you did find this helpful. I did put some more of this information online if you're interested in a foot pain toolkit. That's something that I always tell patients about. This is found at my website, drpelto.com. And in here you can find information on heel pain, front of the foot, middle of the foot, toenail conditions, skin conditions, pretty much everything that you need. Okay, so I hope you guys found that helpful, and have a great day.